Welcome to The Explainer. We're jumping right into the content today because we are setting the stage for an incredible journey into the absolute highest stakes of pediatric cardiac surgery. We're looking at a condition that is honestly as fascinating as it is terrifying, and it requires some of the most precise, elegant medical interventions human beings have ever developed.
Okay, so I want you to picture this. Imagine being born with a window between the two most important blood vessels in your entire body. To really wrap our heads around this, let's use a plumbing analogy right out of the gate. Think of the human heart as the ultimate pump room, right? Your aorta is this massive, high-pressure pipe blasting oxygen-rich blood out to your entire body. Right next to it is the pulmonary artery. That's a low-pressure pipe gently carrying blood to your lungs to pick up oxygen. Now imagine being born with a literal window, a hole connecting these two pipes. What happens? Well, that high-pressure pipe leaks violently into the low-pressure pipe. It is an absolute plumbing catastrophe for a tiny newborn heart.
Medically speaking, this is called an aorto-pulmonary window, or APW for short. The textbook defines it as a congenital cardiovascular malformation characterized by a side-to-side continuity between the ascending aorta and the pulmonary trunk. Now, it is incredibly rare, occurring in only about 0.2% of all congenital heart disease cases. And because it's so rare, fixing it requires an absolute masterclass in surgical precision.
I know this is a pretty dense medical topic, but don't worry, we're going to break this down logically. Our agenda for today is straightforward. 1. What is APW? 2. Types of APW defects. 3. Symptoms and diagnosis. 4. The surgical solution. And 5. Results and survival rates. Let's dive in.
All right, Section 1. What is aorto-pulmonary window? Understanding the defect. To really appreciate where we are today, we have to look back at humanity's long attempt to understand and fix this specific problem. The very first time an aorto-pulmonary window was reported in medical literature was way back in 1830 by a doctor named Elliotson. But here is the wild part. It took over a century before doctors could even reliably diagnose it in a living patient. That finally happened between 1949 and 1951. Then, in 1952, a surgeon named Gross attempted the first successful ligation using a closed technique, which, as you can imagine, was incredibly dangerous. The true breakthrough, that came in 1954, the advent of the cardiopulmonary bypass machine, which allowed for true open-heart operations, finally made reliable repairs possible.
Moving right along to Section 2, types of APW defects and classification schemes. Let's see how surgeons actually classify these literal windows in the heart.
Because not every window is located in the exact same spot. What we're looking at here is the classification scheme recommended by the Society of Thoracic Surgeons Congenital Heart Surgery Database Committee. It brilliantly illustrates the physical differences between the classifications. You can see the red aorta, the blue pulmonary artery, and that clear opening between them. Depending on exactly where that opening sits, surgeons categorize the defects so they know precisely what they're walking into in the operating room.
So, the absolutely crucial point here is understanding these four types. First, we have proximal, or type I, which sits just above the sinus of Valsalva. This one represents a staggering 90% of all cases. Then there's distal, or type 2, which is located higher up. Total, or type 3, is exactly what it sounds like. The defect involves the majority of the ascending aorta. And finally, there's an intermediate type. This one actually has adequate rims of tissue and is the most suitable for potential device closure down the line.
But wait. Here is where things get truly complicated. About 50% of the time, APW doesn't happen alone. It comes with other cardiac anomalies, like the particularly lethal combination known as Barry syndrome. Not only is there a window between the vessels, but the right pulmonary artery is actually growing out of the wrong place entirely, originating straight from the aorta, and the aortic arch itself is interrupted. For infants born with this specific combination, the situation is incredibly dire. Most die shortly after birth without immediate, highly complex intervention.
Which brings us to Section 3, Symptoms and Diagnosis, Clinical Features. The stakes for an infant born with this condition really could not be higher. Without an intact wall to separate the pressures, that massive flow of blood from the high-pressure aorta just blasts into the pulmonary artery, utterly overloading the baby's tiny heart and lungs. These infants present with early-onset heart failure. They're small, underdeveloped, and they suffer from tachypnea, which is rapid labored breathing. They face recurrent respiratory infections constantly. And because of that massive left-to-right shunt, doctors often see rapid aortic runoff, which creates a collapsing peripheral pulse.
Since the early 1990s, diagnosing this grim reality has relied almost exclusively on 2D echocardiography, which allows doctors to actually see the defect in real time. 40%. I really want that number to sink in. If a child is born with this defect and does not receive surgical intervention, the mortality rate in the very first year of life is an estimated 40%. There is absolutely no natural tendency for these windows to just close on their own. Without surgery, the outlook is incredibly bleak.
But here is the good news. Section 4, the surgical solution and repair techniques. We're going into the operating room now to transition from that grim statistic to the heroic modern surgical fixes we have today.
Fixing this requires incredible orchestration. Step 1. The surgical team establishes cardiopulmonary bypass. Basically, they hook the infant up to a heart-lung machine so they can work on a still, bloodless heart. Step 2. They inject a cold cardioplegic solution directly into the heart to temporarily arrest or stop it from beating. Step 3. Once the heart is completely still, the surgeon makes a precise vertical incision directly into the anterior wall of the aorto-pulmonary window itself.
Now, imagine you're looking right over the surgeon's shoulder into this tiny, tiny heart. Through that incision, the surgeon's goal is to completely block that high-pressure leak. So they take a patch, usually made of a synthetic material called PTFE, or sometimes the patient's own specially processed pericardial tissue, and they meticulously suture it onto the posterior, superior, and inferior borders of the window.
Next, the surgeon performs what's famously known as the sandwich technique. As they close up that initial incision, they actually incorporate the front edge of the patch right into the stitching. So the patch is quite literally sandwiched between the aortic wall and the pulmonary arterial wall. It's absolutely brilliant, honestly, because it provides a highly secure, pressure-resistant partition separating those two distinct circulatory systems.
Let's contrast the problem with the solution here. On one side, we have the terrifying problem, the initial incision into a completely merged, leaking vessel. On the other side, we see the elegant, life-saving plumbing solution. The vessels are completely rebuilt and separated from the inside out. The high-pressure pipe and the low-pressure pipe are finally acting independently, exactly as nature intended.
So, how well does this intricate plumbing repair actually work in the real world? Let's transition to the final chapter of our explainer. Section 5, Results and Survival Rates, Postoperative Outcomes.
When we look at hospital mortality after primary repair, the contrast is just staggering. Remember that 40% mortality rate for untreated infants? Well, for isolated, simple APW repairs in the modern era, the mortality rate plummets to just 2.2%. It is a sheer triumph of modern medicine. Now, for complex cases, those with associated lesions like an interrupted aortic arch, the mortality rate is higher, sitting around 13.1%. But considering how uniformly lethal those combinations used to be, this is still a massive medical victory.
And here is the most triumphant data point of the whole explainer: 100%. According to recent long-term studies, for patients who undergo repair for an isolated aorto-pulmonary window in infancy, freedom from needing any reintervention on that repair at 5 to 8 years out is completely 100%. Once it is fixed, it stays fixed. The time-related survival is truly excellent. Which leaves us with this final thought. While open-heart surgery for APW is highly successful, we are always pushing for less invasive methods. Currently, there's no specific medical device designed for a transcatheter closure of an APW. That means fixing it through a tiny tube in the leg rather than fully opening the chest. While surgery is a near-perfect fix today, finding a catheter-based solution for older or higher-risk patients is definitely still on the horizon. So with that in mind, what is the next great frontier in mending the tiniest hearts? We'll just have to keep watching the science to find out. Thanks so much for joining me on this explainer, and keep learning.